So let's come on the back. So if we talk about the muscles which are present on the back, we have quite a few. So the largest and the most superficial or anterior of that is the trapezius muscle, which you can see. It has multiple origins all along the base of the skull, the vertebral column, and it goes all the way downwards. It has insertions both anteriorly and posteriorly. Since we are concerned with the posterior aspect, we'll only discuss that it's inserting at the basically the spine of the scapula. It's inserting at the spine of the scapula. And you can imagine if a muscle is attached like this, if a muscle is attached like this, so when it will contract, it will bring the, basically it will elevate the scapula. So the test which we commonly use to test for the trapezius muscle is we ask the patient to shrug. This action that I'm able to do, this is being performed by the trapezius muscle. It is innervated by, so the innervation, I'll hide it for a bit. So the highest yield thing about the trapezius muscle, and this is what the examiners love to ask about, especially in step 1 exam, in your board exams, in your class exam, shelf exams, is the innervation of the trapezius muscle. And the trapezius muscle is innervated by a cranial nerve that is called the spinal accessory nerve. And this is one of the two major muscles that is being supplied by the spinal accessory nerve, one being the trapezius, which helps you to shrug your shoulders. The other is the sternocleidomastoid muscle, which you can see over here, the thick band of muscle which is coming all the way downwards, inserting at the clavicle. This is the sternocleidomastoid muscle, which helps to move your head left and right. So this is being done by sternocleidomastoid. This is the another muscle that is supplied by the spinal accessory nerve. So what's the function of trapezius? So it helps to elevate the scapula and shrug your shoulders, right? Anteriorly, it also brings the clavicle upwards. And but one of the functions that examiners really like to ask about is that it has similarity when it comes to function with serratus anterior. So that, like we mentioned before, serratus anterior also helps in overarm abduction, the same way trapezius also helps in abduction beyond 90 degrees. And we have talked about the tests which we are supposed to do. Another muscle, so you can see the similarity when it comes to back. There are a lot of muscles and there are a large group of muscles. The same is the case with Latissimus dorsi. It has multiple origin coming all the way from the lower back on the pelvic girdle. It goes all the way up. It has some insertions at the clavicle, but the insertion which we are mainly concerned with is the insertion at the humerus. So like we talked about, so we have this is our humerus, this is the humerus, this is the head of the humerus. The lateral aspect is the greater tubercle, this is the greater tubercle, and this is the lesser tubercle. And between that is the intertubercular sulcus or groove. So we have already discussed how pectoralis major inserts at the lateral lip of the intertubercular groove over here. The latissimus dorsi is a muscle that inserts just in the intertubercular sulcus. So we have two ridges, the medial and the lateral. So the latissimus dorsi just inserts at the intertubercular sulcus. So there is a very common mnemonic that we use, and you must have read in the book, that is called lady between two majors. So we call latissimus dorsi the lady. It's between two majors. We have already discussed on the lateral aspect, we are inserting the pectoralis major. Medial to that is the insertion for in the intertubercular groove. It's the insertion for latissimus dorsi. And on the medial most lip, we have the insertion for, any guesses? We have insertion for teres major, the lady between two majors. Very high yield mnemonic, and it comes up again and again in your exams too. Not the mnemonic itself, but the insertion of latissimus dorsi. Usually, like I mentioned initially in the start of our class, we don't usually necessarily have to learn about the origin insertion of the muscle, but this the insertion at the intertubercular groove and the medial and lateral lips, you really need to know about the insertion of pectoralis major, the latissimus dorsi, and the teres major. It usually comes up in the exam, and I'll tell you its significance in a bit. So its innervation is by the thoracodorsal nerve, and you can imagine its action. So I hope you can see. Yep. So this muscle is actually originating from the backside. It's originating from here, and it goes all the way towards the anterior surface, or all the way towards the anterior surface. It's like this. So when it will contract, so when it will contract, so if I use this humerus, when the latissimus dorsi will contract, it will internally rotate the humerus. It will do what? It will internally rotate the humerus. So if it's like this, and if it's coming like this, when I will contract it, it will move the humerus in a basically medial direction. Inward rotation will occur. Also, if the arm is flexed, and when the latissimus dorsi contracts, it will also extend the arm backwards. Also, if the arm is abducted, so latissimus dorsi can adduct. It can adduct the humerus. So we can see the action. It extends, it adducts, and it medially rotates the upper limb. Then comes the levator scapulae. Levator scapulae has multiple origins along the vertebral column, but its insertion is at the superior-medial surface of the scapula, like you can see. And you can imagine, as the name states, levator, it arises from the word elevation. I'm sure you guys must have heard about the word elevator. So it's actually coming from the word elevator, and it elevates what? The next part of the word, that is the scapula. So it's actually elevating the scapula. And you can see when it will contract, when this muscle will contract, it will elevate the scapula towards itself. It is innervated by dorsal scapular nerve. And let's come on to rhomboids. Rhomboids is another group of muscle which is present posteriorly. We have two major basically components in the rhomboid muscle, in the rhomboid group. We have the rhomboid minor, which is superiorly. The muscle which I'm pointing towards is the rhomboid minor, and this is the rhomboid major. And you can imagine when it contracts, will it bring the scapula towards the vertebral column, or will it push the scapula away from the vertebral column? So you can imagine if it will contract or shorten, it will bring the scapula towards the vertebral column. Okay, and that is the major function of the rhomboids. That is, it retracts the scapula. It retracts the scapula. This is our scapula. It retracts the scapula. So its innervation is by dorsal scapular nerve, and its action is that it retracts and rotates the scapula. Then so we have done the major muscles of the back that we needed to know for the next topic, that is the axilla. So on the left side, we have the superficial muscles, that is the trapezius and the latissimus dorsi. If we look on the right side, we have basically dissected the trapezius and the latissimus dorsi, and we can see the muscle which are rhomboid minor, rhomboid major, levator scapulae. And these are some muscles which we also have to talk about. That is the supraspinatus, infraspinatus, teres minor, and teres major. We'll be going over it in a bit. Another image showing the same thing. This is the trapezius in brown, latissimus dorsi in yellow. And on the right side, we have dissected trapezius and latissimus dorsi, and we can see levator scapulae, rhomboid minor, and rhomboid major. Then comes the rotator cuff muscles. So we have rotator cuff muscle is super high yield when it comes to your module exams, your shelf exams, your step 1 exam, because rotator cuff is the group of muscle which helps you to move the shoulder in all directions, whether it's flexion or extension or abduction or adduction. That is why it's really high yield. And as clinicians, we really need to know the function of these muscles. Why do we need to know this? Because since these muscles are used so aggressively and so commonly, their tears, their inflammation is really common, as well as either it's partial tear or full tear, or basically the inflammation of the tendons itself of these muscles, and impingement which come along the course of these muscles. So it's really important to know about rotator cuff. And I would really want you guys to know the function as well as its innervation. So the muscle which is highlighted in green over here is the supraspinatus muscle. And as the name states, this is the scapula, this is the spine. So this muscle is situated in the supraspinous fossa. That is why it is called supraspinatus muscle. And so it's like this. So it comes, so it comes over here anteriorly. And it attaches on the greater tubercle. So I'm holding it, so I have the wrong bone. Yep. So now I have the right bone. This is the posterior aspect of the scapula. This muscle, it is present over here, and it actually it inserts on the top of the greater tubercle anteriorly. So what will happen is when it will contract, it abducts the humerus. It does what? It abducts the humerus. So if we show on our model, so it's present over here, right? It's present over here in the supraspinous fossa. And it inserts like this. So when I will contract it, and I will move it backwards, so it will move the humerus in this direction. So this is the abduction. And the thing about supraspinatus is that it initiates the abduction, causes the initial abduction, which is 15 to 30 degrees. Usually 15 degrees. In some books, it's written 20 degrees or 25 degrees, but the initial abduction is being performed by the supraspinatus muscle. So if a patient comes to you in your clinic and he or she says that, doc, I really can't move my arm upwards, that might be an indication that the patient has problem with the initiation of abduction, and maybe their supraspinatus is injured, or maybe the nerve which is supplying to the supraspinatus, that is the suprascapular nerve, that is damaged. And after 15 degrees, which muscles take over? That is the deltoid, which help move the abduct the clavicle till 90 degrees. Let's come to the infraspinatus muscle, and you can see infraspinatus muscle originates from the infraspinous fossa of the scapula, and it inserts at the greater tubercle but posteriorly. It inserts at the greater tubercle but posteriorly. So what will happen is you can visualize, this is the origin, this is the insertion, and when it will contract, it will externally rotate the humerus. So this is the greater tubercle, this is the head, and it's attaching. This is the posterior aspect. So it's attaching over here like this, right? It's attaching like this. So when it will contract, it will externally rotate. It's hard to show over here, but you can imagine if it will contract, it will rotate the humerus along its axis, and this will be done in an outward fashion. So it will be external rotation or lateral rotation. You need to know if any muscle is inserting on the posterior aspect of the, and this is a really high point, so I want you to make a note of this. If any muscle is inserting on the posterior aspect of the humerus, that muscle is most likely to cause external rotation. If there's any muscle that is inserting on the anterior aspect of the humerus, that muscle is most likely to cause medial rotation. Please take a note of this. So we can see this is the posterior aspect of the body, and the insertion of the infraspinatus, it's happening on the posterior aspect. So it will perform external rotation or the lateral rotation, and it will also cause adduction. Since when it will contract, the fiber will contract, it can bring the humerus towards the scapula. It will bring the humerus towards the scapula. So this is basically adduction of the humerus. This is the adduction of the humerus. So you can see the innervation is again by suprascapular nerve, which we mentioned, and its action is that laterally rotates. Lateral rotation is another terminology that we use for external rotation. It's the same thing. Let's go forward. Next muscle which we have to discuss about is the subscapularis muscle, and as the name states, it is housed in which area? In the subscapular fossa of the clavicle of the scapula. This is our scapula, and this is the subscapular fossa. So at this point, we were talking about the posterior aspect of the scapula. Now this is the costal surface, and this is where the origin of subscapularis muscle is. And you can see, so this whole image is as if we are looking at our skeleton from the anterior most view, if you can imagine. So I've removed the rib cage, and whatever I'll see is the anterior most portion of the scapula, and this is, you can see on your screen. So its origin is at the subscapular fossa, and its insertion is where? This is the humerus, this is the humerus, this is the greater tubercle, and this is what? This is the lesser tubercle. This is the lesser tubercle, greater tubercle. The insertion of subscapularis muscle is at the lesser tubercle. And just imagine the golden rule, which I just told you guys. If any muscle is inserting on the anterior portion of the humerus, it will do what? It will do medial rotation or internal rotation. And this is the anterior humerus. So this muscle is actually inserting on the anterior portion of the humerus. So this muscle will actually cause the medial rotation of the scapula. Another function you can imagine is when the scapula will contract, when it will, when the subscapular muscle, I'm sorry, I'm jumbling up words. It's okay. This is my first time ever recording a video. So if this subscapularis muscle will contract, it will actually adduct the arm. So you can imagine that if it shortens, so it will bring the humerus closer to the body, and that is called adduction. So let's see the function. So its innervation is by upper and lower subscapular nerves, and it medially rotates the arm, as well as it causes adduction, which I haven't mentioned over here. The other muscle that we have to talk about is the teres minor. This is also the part of rotator cuff. It originates from the scapula. As you can see, it originates from the scapula, and it inserts where? It inserts again at the greater tubercle. So it inserts at the greater tubercle. But on the posterior aspect. Okay, it inserts at the greater tubercle, but at the posterior aspect. There was another muscle that was inserting at the greater tubercle and the posterior aspect. Can you think of that muscle? Okay, that muscle was actually infraspinatus. That was inserting at the greater tubercle at the superior aspect of the greater tubercle. This is inserting at the middle aspect of the greater tubercle posteriorly. And I will repeat it again. If a muscle is inserting at the posterior surface of the humerus, would it cause external rotation or internal rotation? So if you're thinking external rotation, you are perfectly right. So I hope it makes sense. So you can imagine when it will contract, it will rotate the humerus along its axis. It will rotate the humerus along its axis, and there will be external rotation, as well as if the humerus is abducted, it will also cause adduction of the humerus. It's the innervation of the teres minor is done by axillary nerve, and it again laterally rotates the arm, and it causes somewhat adduction of the humerus. So it's really important. So when it comes to the musculoskeletal system, it's important to know about all of these anatomy, that is the part of the bone, the anatomy, the grooves, the sulcus. I get it, but the most high thing about knowing the anatomy of musculoskeletal system is the clinical correlates. So in your clinics, when you go in your clinics in third year, fourth year, in your step 1 exam, in your step 2 exam, or in any exam, what's usually asked are the clinical correlates that are relevant to your clinical setting. And supraspinatus, or the muscle which we just talked about, the rotator cuff muscles, since they are used a lot, and so their injuries are also very common. And the injury for the rotator cuff muscle is rotator cuff tendinitis. You can imagine there are 4 muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. Any of the tendon of these following muscles can be inflamed. So that is because of overuse or hypertrophy, whatever. That is termed as rotator cuff tendinitis, and it's a very common injury in athletes who tend to do a lot of movement of their arms, especially baseball pitchers. So the supraspinatus injury is very common in people who do overhead abduction. So people who are from the US, they must be knowing that the baseball pitchers usually have problem with supraspinatus muscle, and people who watch cricket, they know that usually fast bowlers typically have the injury with supraspinatus, as well as any of these muscle of the rotator cuff muscles can be injured because of overuse, and that is named as rotator cuff tendinitis. There's another pathology that is called adhesive capsulitis. That is, you must have commonly heard in your homes or in clinic. There's a term known as frozen shoulder. So your shoulder is actually not freezing, but what's happening is that the capsule of the shoulder, that is the sheath which covers the whole of the shoulder joint, there's inflammation of that. That is why it's called adhesive capsulitis. And because of the inflammation, there is limited range of motion in the shoulder region. And the population where it commonly happens is the diabetics. In a clinical exam, in your exam, mostly you guys will be given a clinical vignette in which there will be a diabetic 70-year-old male or female who has typically had a poorly controlled, basically glycemic control for many years, and now has presented with shoulder pain. So one thing that you should be keeping in mind, that is adhesive capsulitis. Also, it happens in immunocompromised individuals too. So just the summary of everything which we have. This is the anterior aspect. You can see the subscapularis muscle in green. And this is the posterior aspect. This is the spine of the scapula. Superior to it, we have this supraspinatus muscle. Inferior to it, we have infraspinatus. And then we have teres minor. Let's talk about axilla.